Hello and welcome back to PEMChat. Last month, we began a discussion with Dr. Chuck Gomez and John Appel about common pediatric orthopedic emergencies. Today is going to be the second part of that series. Now, last month, we talked about things that affected the upper body, and today we're going to cover the emergencies that affect the lower body. So thanks for being here, and we're going to jump right back in that discussion with Dr. Gomez and John Appel. All right, let's talk about the lower body. SCFE.
Yeah.
What is a SCFE?
Yeah, SCFE. So slipped capital femoral epiphysis. So that's when the growth plate in the proximal femur kind of is weakened. Can be from several things, but kids with metabolic problems, endocrinopathies, are your atypical SCFEs. Those kids kind of can get collapse of the epiphysis earlier than most. The majority of the time, it's kind of your overweight kid that gets kind of this chronic pain, kind of limping, and they can have kind of a slow progression of a slip in the epiphysis that will need surgery. And if it progresses without any intervention, can be sometimes catastrophic.
I've only seen one of these in the children's ER so far, and it was a tiny girl. It was the opposite of what I expected, but she came in like her pain was just incredible. She was slipped, and it was like she had a femur fracture. I mean, it was just incredible. We had to give her fentanyl just to get her out of the wheelchair into the bed. She was just hurting so badly, and didn't quite fit the bill that I guess we normally see as far as her body type goes.
Yeah, well, so in SCFEs, you can have there's several different types. You can have kind of an acute SCFE where it has started to slip and then they have an injury and it turns into like a fracture that happened acutely. And so those are probably the ones that really hurt because they had a progressive slip that maybe you didn't really know about, but then they fell and it turned into an acute one where the epiphysis is unstable. You can have acute on chronic, so they've had it chronically and then fell and that thing fell off. You can have chronic ones where it's just been this slow progression of a slip. So, it's kind of a continuum. It's not just one thing or nothing. And some of the kids with endocrinopathies or like young kids, they could have like this kind of slow the slow chronic slip and then have some kind of injury that causes an acute slip. So in some of these patients that have chronic SCFEs, if it's at an outside facility or a pediatrician, we tell them to make them non-weight bearing, let them come see us, and then we'll do something to stabilize it. Acute ones are a little bit different than chronic ones, but both will require stabilization.
Yeah, so those go to the OR. Okay, what about a patella dislocation?
Oh, yeah, patella dislocations. I don't get to see those too much because you guys take care of a lot of those.
Okay, from that angle, I was going to ask. So when we pop these patellas back in, at that point, we assume there's some laxity, right, tendon or ligament issues. Do these get surgically repaired, or is this just something that will take care of itself?
Well, my son's did. He ruptured the ligaments and had to have some sort of like little brace thing put in place to keep his patella stable.
Yeah, so a lot of it depends on the history. If it's a patient that has a first-time dislocation and it was reduced, and they have a lot of swelling and an effusion, then when they come to my office, then I do a couple things. One, they get an MRI because when you have a dislocation and the patella goes lateral, it can knock off patellar cartilage or cartilage from your femoral condyle. And so I MRI these to make sure, one, there's not a big loose body within the knee. If there's a huge loose body, then that will need to be either taken out or then taken out and fixed surgically. And so when I see first-time patellar dislocators, yes, I'll do an MRI. I will take the knee immobilizer off. In my office, we have patella dislocation braces. They're called J-pole braces, and they kind of bolster the lateral aspect of the knee, specifically over the patella, to prevent lateral subluxation. If we MRI them and there is no loose body, if there's no cartilage damage, if there's no big osteochondral defect that needs surgery, then the first line treatment is a physical therapy, specifically for something called VMO, strengthening your vastus medialis obliquus. That's the muscle that attaches medially to the top of the patella and stabilizes it. And also, when we get the MRI, we look at some of the other parameters. We don't need to go into depth, but we look at certain angles and relationships to the femur and where the patellar tendon is attached. If those numbers kind of are way too large, those kids get surgery. But kids with normal kind of measurements, no intra-articular loose bodies or defects, they get a brace, they get PT for VMO strengthening. And I don't necessarily reconstruct the ligaments, because anytime you dislocate something, in order for it to dislocate, stuff tears. So I expect that. That's why I don't order MRIs on ankle sprains, because it's going to show me what I know has already happened. Mm-hmm. Torn ligaments, stretched out ligaments. And so first time dislocators get an MRI. And if there's nothing abnormal, they get therapy.
Yeah. You know, in the ortho world of adults, they MRI all these joints. Do you feel like you do that as much in kids? I always wonder that. We get parents all the time that come to the ER and they're like, we need an MRI. And I'm like, well, not here, you don't. But how much are you doing that?
I don't order a large amount of MRIs.
Okay.
But again, first time patellar dislocation kiddos get MRIs to rule out those things. If all those things are normal and they don't need any surgery, then we do therapy. If that kid gets repeat dislocations, then we talk about reconstructing the MPFL, which is giving them a new kind of ligament over the medial side of the patella. But for other things, I don't jump right to MRIs. A lot of kids come and they're like, my ankle hurts, I need an MRI. Then we get an MRI and it says that there's attenuation of the ATFL, there's a little bit of attenuation in the CFL, and then the family comes back and they're like, this is abnormal. Well, I sprained my ankle probably 10 years ago, and if I MRI'd it, my ATFL will look attenuated and maybe a little stretched. And so, in kids, I don't order a ton of MRIs, but in the right circumstances, I probably order a lot. But I think by and large, to the proportion of the amount of patients I see, I don't order that many MRIs.
Okay. Yeah. Good to know. What about tib fractures?
Yeah. So
I guess we could start with
a big, very broad topic. I think for providers, maybe, tibial shaft fractures are obvious. So there's not a lot of nuance there. Other than compartment syndrome stuff. But this is a good kind of segue into proximal tibia fractures like a tibial tubercle fracture. Tibial tubercle fractures happen in a lot of kids playing jumping sports, football, basketball, sometimes even soccer. And
trampoline.
Yeah, it can happen in trampoline also. And so, the tibial tubercle is in your proximal tibia, and it's what your patellar tendon is attached to. And in kids that are growing, your proximal tibia growth plate can be vulnerable, because as your proximal tibia starts to close, so when you're nearing skeletal maturity, it closes from posterior to anterior, and it closes from proximal to distal. And so the whole kind of growth plate around the tubercle closes in a very predictable fashion. So kids nearing skeletal maturity, when they have like either a contraction of their quad and they injure it, the patellar tendon will pull off the bone. Mm-hmm. And there are different types depending on kind of where you're at maturity-wise. And that's why these different fracture patterns happen in certain age groups, because of the timing of when the growth plate is closing. So the older the kid nearing skeletal maturity, sometimes they'll just have just the distal tubercle pop off. The kids that may be a little bit younger, theirs may extend all the way into the joint because they're at a different place physiologically in terms of their growth plate closing. So sorry, I digress in the orthopedics. The reason why that fracture is important is because when that fracture displaces, there is a blood supply to your anterior knee, specifically an artery called your anterior tibial recurrent artery. If you have a really bad tibial tubercle fracture, it can tear the anterior tibial artery, and you can get anterior compartment syndrome in your leg. And so if you're at an outside hospital and you see a really bad tibial tubercle fracture, that probably needs to be transferred to the children's hospital so we can watch it and so we can fix it the next day. Because at the very least, it needs to be monitored for compartment syndrome.
Okay.
I've taken care of one compartment syndrome as a practicing orthopedic surgeon, and it was a kid with a tibial tubercle fracture.
Okay. So they get admitted for obs regardless of, are they all surgical?
Yeah, and I'll fix them then, yes, because
Okay.
they're displaced. So if you're examining them and they can't extend their leg, then the whole extensor mechanism is disrupted and they need surgery. And
Yeah.
So that also kind of goes into patellar sleeve fractures. I don't know if you've seen a lot of those, but kids that are
I don't even know what that is, so no.
at the patella where it originates from, the patella, kids can have a similar injury to the mechanism of what causes a tibial tubercle fracture, and the sleeve of cartilage will get pulled off the patella. And sometimes you don't really even see it because it's cartilaginous sleeve and periosteal sleeve. And it will just look like on x-ray, the patella is high riding. They'll have a lot of pain. You may even palpate a gap where their patellar tendon is. So a tibial tubercle fracture, a patellar sleeve avulsion fracture, those things are the equivalent in the adult world as a patellar tendon rupture.
Okay.
They need surgery, or else you won't be able to extend your leg.
But this is a kid that on exam, you're going to do flexion extension and they're not going to be able to do that, right? Like that.
Correct.
Okay. So, that's part of most people's exams, I think.
Yes. And typically there's an effusion.
Yeah.
There's swelling.
John, let's talk a little bit about toddlers' fractures. We see this a lot in the children's ER. My kid's 2, 3, fell down, comes in, won't bear weight on their leg. Talk to us about that.
I think probably the best way to address that is looks broke. No. Axe broke, probably broke, right?
Right.
So basically what I mean by that is these kids are not at their baseline. They won't walk. They won't bear weight. And most of them have, tenderness right over that fibular physis. It's just, so. But sometimes at that age, it's just they went from walking and running to not walking and running after their fall.
Yeah, Jen taught me a great exam skill. Like you pick this kid up by the arms, you try to put them down on the bed and they act like a flamingo. They lift that leg up. They will absolutely not bear weight on it. And they do it every time. It's incredible. And I've had kids that weren't tender over the bone, but like you could just appreciate a little bit of warmth, in that one spot that's a little different than, I try to compare both legs. So we image them, and how do we treat them? Let's say we get an image and you don't see a break.
Yeah, I think it still goes back to if they were ambulatory prior and now they refuse to ambulate, they probably have a Salter-Harris 1 fracture, right?
Yeah.
That physis. So.
And these are usually where? Where is this fracture usually?
Distal fibula, typically. I mean, you can get some distal tibia as well, but I think fibula is probably the most common. But either way, if they're otherwise neurovascularly intact and there's no obvious fracture, but they just won't bear weight, I typically put them on a little posterior splint and have them follow up with ortho.
You do a long leg posterior?
Not for ankle. I don't typically. Would you rather us put it long leg for distal Salter-Harris 1 fractures?
I think if you think it's a distal fibula fracture, then a boot is fine.
Yeah. Well, a lot of controversy, I think, amongst providers about who gets a boot, who gets a long leg. What are your thoughts?
I don't think you're going to go wrong putting a splint on. No one's going to get upset with you For me, I like boots because they'll ultimately go into one of those anyway. And I'll let them weight bear in the boot while they make that transition to weight bearing out of it.
And some of these kids are like 70 pounds, and the parent has to carry this gigantic kid, they're not all huge, but, in 2025,
And
some of them are.
I think the orthopedist in me, I don't know if this is too much information, but the orthopedist in me, I always think about kind of the mechanism of what happened. To kind of digress about physiology for a second, bones are strongest in compression, right? We're upright biped animals or mammals, that walk on our feet. So bones are strongest in compression. They're next strongest in bending, right? And they're weakest in torsion. So like twisting a bone, causing a spiral fracture. So if you have a kid that's running around the house in socks and he kind of slips and falls, that's probably more of a torsional stress. And so a kid that is running or steps on a piece of paper and slips or is in socks and slips, to me, that's introducing a little bit of torsional stress. And so I will treat those like maybe it's a tibial shaft that's non-displaced, and I maybe put them in a splint. If it's a kid that like fell and landed right on it, then maybe that's like a small occult fracture that's more transverse or oblique. Same thing, I may put them in a splint. If it's like a sprain or a situation where they're just tender over the fibula, that kid will get a boot.
Okay. Yeah, in my former life, I kind of learned you're a little bit more liberal with your using a boot with fibula in general, but tibias are generally more of the non-weight bearing fractures.
Yeah.
Okay.
Yeah.
And you're okay with a kid with like a suspected toddler's fracture going home in a boot and walking on it?
I don't know. It just really depends on if it's like a kid that's not walking, a little bit bigger kid. I would rather that kid, like if I suspect a tibia, be in a splint.
Okay. Yeah. Then make them non-weight bearing. Okay. All right. We would be remiss if we didn't at least talk tiny bit about osteomyelitis and septic arthritis. We did do an entire podcast on this, and so I don't think we need to spend a lot of time talking about it. But, if you're working up a kid with bony tenderness and fever, tell us a little bit about what we're looking for, John.
Well, this one hits kind of close to home. Unfortunately for Chuck, I have him on speed dial. And the past few times he was on call, I could think twice in the past 6 months where I had kid with suspicion for a septic joint. And so that's kind of fresh in our mind. But I think he's going to stop taking my call and just text the resident, because the last one was not smooth.
I'm not on call today. Yeah, we talked about it in the other podcast, but if a kid is not bearing weight on a leg or they're not using an arm, that is never normal. Kids don't make symptoms like this up. You have to take that seriously, and so definitely something worth looking into. I'm again don't want to spend a lot of time talking about it, but inflammatory markers, consulting with ortho, they're going to give us additional guidance. Anything else you'd like us to do in the ER, Chuck?
No, I think prior to me getting here, there's kind of a good system in place that you guys have in kind of addressing these. If there's concern for something else going on, like not just a septic joint, maybe osteo or subperiosteal abscess, then we have the ability to get MRIs kind of in the morning. But for me, I think that's good. And that kind of can limit potential anesthesia time, because they'll need anesthesia, smaller kids, to get an MRI, and then we can go right from there to surgery. But sometimes I'm a little bit more aggressive, because if it's like a septic hip and the story sounds right and the inflammatory labs are elevated and they're febrile, they're not walking, they have a leukocytosis, and we image it and there's like an effusion, I think I'm obligated to get fluid, and that's really important, because if you have like a really bad MRSA infection in the joint, then you can start having cartilage damage within 6 hours. And so that's why when John calls me and these kids, and I look at them and they've had an ultrasound and there's an effusion, if we are able to, we'll sedate the kid in the emergency room and I will aspirate the hip under ultrasound, because I'm more aggressive at that because I don't let those sit all night until the next morning to get an MRI. If I examine the kid and I don't feel as though it's septic, but there's a lot of stuff going on, then I can wait for the MRI the next morning. But kids with osteomyelitis have kind of this kind of prolonged history. Sometimes their CRP can be even more elevated than you would expect in like a septic arthritis. So there's a lot of nuance to it from a orthopedic surgeon, how we treat it. And I would say probably me and my partners vary a little bit because I like to aspirate the hip. And I'm aggressive at washing them out because I would rather wash out a hip that really didn't need it, but get on top of it than wait 12 hours to get an MRI and then wash the hip out. So that's...
Yeah, because Jordan was saying usually we send them to MRI, they're sedated. They do it together, right? So they're getting their imaging plus you're aspirating the joint while they're under sedation.
So, well, no, they go right to the MRI machine. And while they're there, I usually sit in the MRI room and am looking at the images as they come over. If there's a large effusion, then that's when I decide if I'm going to go to the OR or not. And so if I see a large effusion, then yes, I'm going to the OR because I'm going to go get fluid. I'm going to wash it out. I'm also going to wait for the scan to be finished because sometimes there is a concomitant like subperiosteal abscess or there's osteomyelitis. And so that's one of the reasons why we like doing this MRI protocol, because sometimes if we wash a hip out, there's a subperiosteal abscess that we can't see. And then it's been a day, their labs keep going up. Then we have to get them into the MRI machine. Then we have to take them back to surgery. So it's kind of a challenge for us because we want to wash the joints out expeditiously, but we don't want to miss like a subperiosteal abscess. But for me personally, I would rather wash the hip out and get that out of there than wait a long time to figure out whether or not they have a subperiosteal abscess that also needs surgery. So for me, maybe they get 2 surgeries instead of 1, but I've washed the joint out and it's not infected because ultimately that is going to be more detrimental to the patient long-term than a subperiosteal abscess.
Mm-hmm.
So on presentation these days when you're not on call and you're not sitting in the hospital where I call you, kid presents with what we're concerned about being a septic hip. So of course we do inflammatory markers, blood cultures, all that good stuff. Do you recommend on those kids in the ER doing plain films and ultrasound every time? Is that beneficial or?
I would start with the plain film. Yes. I would always start with a plain film and then kind of go from there. I don't think everyone needs an ultrasound, but I think sometimes it's warranted because definitely if there's a large effusion and they have elevated lab values, and this is something that has gone on in the past 24 hours, then for me, I want to aspirate that and get fluid. And so if it's someone where it's been like 4 or 5 days, for me, that kid needs an MRI because there could be a subperiosteal abscess, there could be osteomyelitis. It only takes 6 hours for CRP to elevate. So that's a pretty acute inflammatory marker. So if you've got like a 12-hour history of progressively worsening hip pain, fevers, inability to weight bear, in the right patients, I won't even aspirate it. I'll tell the family we should just go right to surgery.
Mm-hmm. Yeah. All right. I don't think I've ever done an ultrasound just routinely. I've only done that if ortho asked me to get it.
Well, this is the truth. Before he came, I'd never seen anyone at bedside do an aspiration.
Do a joint aspiration.
Wait for the results before they decide on what they're going to do. So This is, I don't know, maybe it's because you're newer and so you have later training, or is this just variation? And
it's probably
it's probably just variation in training. Like I said, I did my fellowship in Cincinnati, and in Cincinnati, that's the algorithm. If you come in and you have kind of these symptoms, and a lot of times the ED staff would have gotten an ultrasound of the hip. If there's an effusion, then we had a protocol to aspirate the hip. I think the really cool thing that we have at Erlanger that most hospitals probably have, it's just a little bit pricey, and I think it can be justified for us because we don't use it all the time, but we have something called a joint infection panel. So typically what you do when you aspirate a joint in an adult or in a kid, even what we did in Cincinnati, is you would get the fluid, you would send it to the lab, and they would do like a fluid analysis and a cell count. If the cell count has a white count of 50,000 or more, that's septic joint, they're going to surgery. If they have like 90% PMNs, then you could say that's probably an infected joint. But here we have a joint infection panel, which is really great because it PCRs like 30 organisms, and depending on the age can vary on what's common, but MRSA can happen, Kingella can occur, and Kingella can be kind of tenuous in culture anyway. So this PCR test that we get, if we get enough fluid and they PCR all these different organisms and it's negative, then it's a pretty good chance that it's not a septic joint. And so in those kids, I watch them with close follow-up. But that test is great because it only takes an hour and a half, just as long as like a cell count would.
Yeah, that's awesome. I didn't even know that
PCR
existed.
For all these different organisms. And so I will do that on the kids that I aspirate in the ER. And so some people in the country, right, that's the thing about surgery in probably most disciplines. If you ask 10 pediatric orthopedic surgeons how to fix one problem, you might get 7 answers. And so some people, their algorithm for septic joints are to take them to the operating room, to aspirate it while they're asleep, send it to the lab, keep the patient asleep, sit and wait an hour or hour and a half until there are lab values that come back and you can make a decision. And so that's why, if able, sedating them in the ER and aspirating them, I've done that in fellowship. I did that in residency. We maybe save the healthcare system a little bit of money, and the families, and maybe prevent an admission and surgery. And if we PCR these and it's all negative, then we don't have to go to the operating room or to surgery.
I mentioned you get your answers sooner too, right?
Yeah, you get your answers on there if there's an organism that is present on the PCR of the fluid.
Yeah, and then you know what to treat. But if it's negative, they could go home and see you in the office in 2 days.
Yeah, if it's negative at that point, I kind of treat it like synovitis.
Okay. So just symptomatic support. Well, we've covered a lot of ground today. The one last thing I wanted to ask you mainly, Chuck, is what ortho resources do you use? I tend to use Ortho Bullets. I'm curious to see what the two of you guys like to use. Do you have any gems on the internet you like to use?
I think Ortho Bullets is good. Just for some quick reference information. I have a lot of textbooks in my office that I look at and on my computer when I kind of do more of a deep dive into something. But typically, yeah, if I'm just telling the resident, hey, look this up real quick, I think Ortho Bullets is pretty good.
What about you, John?
I use Dr. Chuck Gomez. No, in the ER, I just up-to-date's a huge help.
Yeah.
Even with ortho.
Okay.
And once again, it is really nice just having ortho residents that we can bounce things off of.
Yeah, they're so accessible to us. It's hard not to call them.
Yep.
Well, I want to thank you guys, both of you, for being here today. It was fun to hang out with you and pick your brains. You've gotten so smart, Chuck. It's crazy. It's good to have you on our team, and we can call you when we need you. Thank you guys for both coming.
Yeah, no, I am very happy to be here and to be back at Erlanger. This place has meant so much to me. From a ER tech to med student to surgeon. I couldn't be happier to be back, to give back to a hospital that has given me so much in my life that I value. It's where I met my wife, who's an ER nurse. It's where I figured out that I needed to be the one making hard decisions for families and having conversations with them about treatment. And it's really kind of where I grew up. So I will always love Erlanger for better or worse. Feel like we can always be better at our jobs, and I'm happy to be here moving forward to kind of make that happen.
Tony, I think it's kind of neat. I mean, you and I kind of helped raise, Dr. Gomez here, right?
We totally did.
It's true. It's true. It's true.
Now, we're glad you're back, man. It's so nice to have someone that we can put a face to and have a conversation with instead of always kind of feeling intimidated when we call, Anyway, glad you're back.
Yeah, I'm happy to be back. And again, that's why I'm here. That's why I enjoy taking care of kids. You can call me anytime. Yeah, I never mind.
Yeah. Erlanger's all of our homes. I mean, we've all been here like basically our entire careers. It's crazy. So it's a good place. All right. Well, thank you guys. I appreciate you. And I'll see you at work.
Bye, Tony.
Hey, PimChat listeners, thank you so much for joining me over these past 2 episodes to talk about common orthopedic emergencies with Dr. Chuck Gomez and John Appel. These guys are by far my favorite ortho bros, and I'm so glad that they joined me for this episode. Thank you guys for being here. So next time, we're going to talk with Dr. Whitney Buss about pediatric DKA. Now, Dr. Buss is a type 1 diabetic, so I can't think of anybody more qualified to talk about this topic, not to mention the fact that she just happens to be one of the most incredible physicians I've ever worked with. So we'll be back next month to pick her brain about all the different eccentricities of how pediatric DKA is different and how we need to be careful in this population with our management. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.